What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
What's up, everybody? This is Dr. Zach Baker here on the Strength and Knowledge Podcast, and I have got Dr. Bami Adu with us today. And he is here again for our monthly research article feature, which is part of our journal club of our sports residency that we have here at R2P. The month of October focuses on the knee. The month of November focuses on the shoulder. So we had Bami on last month talking a little bit about gait mechanics following ACL procedures. Now we're going to be talking more shoulder-oriented. So, Bami, what was the article that you picked for the month of November?
So this article was acromial-humeral distance and cerebrospinous tendon thickness in people with shoulder impingement syndrome compared to asymptomatic age and gender-matched participants.
Oh, that is a mouthful. I think Christian had the easier article title. I think you went above and beyond with that one, but. What was kind of your thought process or your reasoning for picking this article, or I guess what made you interested in this article?
Yeah, so, I think a lot of people come into the clinic with shoulder pain, so I kind of wanted to look more into how we could better serve these patients with kind of those vague shoulder pain that come through like direct access. So this article really kind of looks at what happens kind of in that subacromial space, and, it's been believed before that it's usually a narrowing of the space, and that's why they used to do a lot of subacromial decompression surgeries. But this article, kind of, as we go into it, you'll see that this article found that it's not really a narrowing of the space that's causing the problem in there. It's more that subacromial space is actually getting wider, and as that space gets wider, the cerebrospinous tendon is also getting bigger as well, and that's what's kind of causing the impingement that people are feeling in their shoulder.
I think shoulder impingement was something in school, coming out of school, and honestly, in the last 10 years that I've been practicing, I continue to want to learn more and more about it, because every time I think I've got it figured out, a different patient with impingement comes in that kind of stumps me for a little bit. It forces me to go back to the drawing board, reflect on what we did in that specific case, look back at the literature, see if anything's changed. But I do think, and we'll get into this a little bit later, that regardless of the patient that comes into the clinic, there's going to be certain commonalities and certain themes when it deals with shoulder impingement of things that we want to be mindful of, that we're looking at, and things that we are addressing from an intervention standpoint. But I like the selection of this article because I think oftentimes in PT we get very hung up on what we focus on. What do we evaluate? What do we intervene on? We think very external. I think sometimes it's good to also get an appreciation of what's happening internally and not forgetting about the medical side of these injuries and of these pathologies. And I think if we have a good understanding of what's actually happening from a physiological standpoint, from an anatomical standpoint, it gives us a better appreciation of where may we find the most or the least success with different intervention options, whether it's conservative intervention in the PT field, or maybe we're going into entertaining some of our more invasive options with surgery, or where does somebody maybe potentially just need pharmacological intervention from a medication standpoint. So, Bami, with this article, do you mind talking about the types of population that they were looking at, the demographics? Were there certain things that they were including or trying to exclude from this?
Yeah, so they had 78 patients between the ages of 40 and 80, and the reason for choosing that age group was because they found that most of shoulder impingement occurs in that age group. So there's 39 asymptomatic individuals, and the asymptomatic individuals, they had to have no pain in or around the shoulder while performing ADLs in the previous 3 months, no treatment for shoulder symptoms within the previous 3 months, and that they've never had previous shoulder treatments for more than 3 weeks. And there was also 39 participants who did have, in the symptomatic group, who did have shoulder impingement, and they qualify for this group by having shoulder pain greater than 3 months. They had to have positive of at least 3 out of 5 special tests for shoulder impingement. So they used the NIRS test, Hawkins-Kennedy, painful arc, empty can test, and external rotation resistance test. and they had to have a confirmed shoulder impingement by a radiologist using ultrasound.
And I'm glad that you pointed out we have an asymptomatic and a symptomatic group, correct?
Right. Yep.
But all of them are confirmed impingement patients.
Yep.
Perfect. So I think being mindful from the clinical side of things is what shows up on imaging, what shows up on testing is not always going to be indicative of how an individual is living and feeling on a day-to-day basis or what they're able to tolerate or perform. And I think a friendly reminder is if we go searching for something in an evaluation with testing, we can often find things, but it may not have a direct influence on their current symptom profile or their ability to perform tasks. But I do think it also goes into the other side of the coin of just because somebody is not currently having discomfort does not mean that they are perfectly structurally intact or a sound individual. And then that's really where clinical decision-making and a little bit more detective work goes in to really determining when and how does this matter and when and how do we choose to intervene on this. So, Bami, that was the population that we were dealing with. What were just the overall methods of this research? What were they looking at? What were they trying to find? And then after that, you can just kind of roll right into what did they actually find?
Yeah, so they use ultrasound to measure the acromial distance and the cerebrospinous tendon thickness, and they used sonographer, and the results were interpreted by a radiologist. For the acromial distance, the participants were seated with their trunk in kind of a neutral position and their arm by their side, and they measured the shortest distance between the acromion and the humerus, and they did this by locating the inferior aspect of the acromion first, and then the superior aspect of the humerus, and they measured this in both the symptomatic and asymptomatic group. And then for the cerebrospinous tendon thickness, they had the participants seated in a neutral trunk position as well, and the elbow was flexed in 90 degrees, and the shoulder was extended. And for this one, they measured the superior and inferior aspects of the tendon, and then 10 millimeters lateral to the long head of the biceps tendon. So ultimately what they found in these was that subacromial space and the cerebrospinous tendon thickness measurements were greater in the individuals with the impingement syndrome compared to the controls. They found a positive linear association between the subacromial space and the cerebrospinous tendon thickness. So as a tendon thickness increased, so did the size of the subacromial space. And then for some secondary endpoints that they found was that there's no difference in age or height between the groups, and that participants with the impingement had a greater weight than those in the asymptomatic group. But there is no linear relationship between the tendon thickness or the subacromial space and their DASH score, which is a disability index test for the impingement group.
And then after going through the exams and after finding these results, you alluded to it earlier, but what's kind of the take-home message? What do you feel like you learned? What did you take from this? And then I would love to get into just a quick conversation of what does this mean moving forward? And if we have these findings, how does it influence us, if it influences us at all within the clinic?
Yes, I think first you kind of mentioned like looking internally. So it was always believed that your subacromial space was getting shorter with this impingement syndrome. But this article proves that it's not necessarily getting shorter, it's actually getting wider because the cerebrospinous tendon is also getting bigger, right? So now we're thinking about treating this as like tendinitis, right? Like a rotator cuff tendinitis type issue. And it can help us kind of clue in on how we want to evaluate the patients and certain things that we're looking at when it comes to overhead motions, where they're getting impinged at what point, and how does the quality of movement also look like for these patients. So I think big picture, this article kind of gives us as clinicians a better idea that when someone just has a very vague diagnosis of shoulder impingement syndrome, just by reading this article, it gives us a kind of an entry point or a starting point where to look at. And I think another big thing that this article tells us is that, we could have that conversation with our patient, right? Where patient is having those impingement into their shoulder and, doc wants them to get surgery or they're thinking about opting for surgery, that trying physical therapy, right, because we know that a decompression surgery may not be as effective as you once thought. So trying PT could be helpful for these patients.
Yeah, and I think of shoulder impingement very similar to how I think of like patellofemoral pain for the knee. And it's a highly prevalent issue for individuals, but there's a wide variety of ways that you can go about treating patellofemoral pain, and there's a wide variety of things that can influence. It can be anatomical on how the patella sits in the trochlear notch. It can be due to strength deficits. It can be due to mobility deficits. It can be due to motor control and movement quality. It can be purely just because of activity volume. So there's a lot of different ways and a lot of different answers as to how you may treat patellofemoral pain. And I think the same is appropriate for shoulder impingement. And when we talk about surgical intervention on shoulder impingement, I think oftentimes when you're considering surgery, there's going to be a wide variety of things that need to be considered, and potentially some other things within the joint or just within the shoulder area that may or may not benefit from surgery. And I always encourage patients just to have that conversation with the orthopedic if they are going potentially down the surgery route, just getting a clear understanding as to what's the intent or what's the hope for the surgery. What are we going to do while we're in there, and what are we anticipating that's going to cause or allow us to do moving forward. And then for some individuals, like you had mentioned, it's a coin flip, and they could go conservative or they could go surgery, and it's not really an urgent or a pressing matter, and we have that ability to go either way with it. And I think what this article shows as well is there's some conditions where, whether it's just, in this case, isolated shoulder impingement, where if there's no other concomitant injury going on or pathology going on, surgery or invasive procedures, it may not be the first option. And it doesn't mean that it isn't an option, but it may not be as first choice as what we may have thought previously. So when somebody's coming in expressing symptoms or they have a referral for shoulder impingement, what are just some things that can influence shoulder impingement, or what are some things that can lead to shoulder impingement that come top of mind for you?
Yeah, so when it comes to shoulder impingement, I think we have to look at, first we want to look at lat length and kind of look at their pec minor length, seeing how they're trying to achieve overhead mobility. So looking at if there's compensation elsewhere, or are they limited through kind of tight muscle, or are they limited through kind of mechanical thing going on inside the shoulder? So we're looking at rotator cuff. We also look at the labrum, and then we also want to look at any tightness in and around the shoulder if those muscles are limiting them from getting that overhead mobility.
Good. And I think when we think of shoulder impingement, mobility comes into mind very quickly. And I think if we don't have the ability to get into a certain position and we're trying to force that position, we're probably going to get some friction in areas that we wouldn't normally get friction, or at least not to that degree. And you had mentioned the example of going overhead, and I think of throwing athletes. I think of individuals either competitively or recreationally in the weight room doing overhead lifting tasks, and they're trying to press a barbell overhead, but they can't even get the weight of their arm overhead in a productive and optimal fashion. So you compound that lack of movement with increased resistance, with increased volume, there's going to be a tipping point somewhere where something has to give. So mobility is a big bucket. I think of strength and stability as well. And oftentimes we have these large muscles around the shoulder. We have our deltoid, we have our pec, we have our lats, we have our traps. We have a lot of muscles that are capable of producing a high level of force. But we have the rotator cuff, and we have some of our periscapular muscles that are responsible for helping to act in a synergistic manner to coordinate that movement. So I think going into the weeds a little bit with strength testing and really teasing out what these individuals do well, where some of the weak links in that shoulder may be for the types of activity that they're experiencing impingement with is important to go through as well. And that's no different than the conversation we had with last month when we were talking about returning to running following ACL. If we don't have requisite quad strength, running is not going to go well from a mechanical standpoint. Same thing if we don't have optimal rotator cuff or periscapular strength to accommodate some of the positions or movements our larger muscle groups are trying to do. We may have some humeral head translation that happens a little bit more exaggerated than what we would like. or just the sequencing of those movements and the coordination of those movements may not be as ideal as we would like. So this is a topic that we could go a wide variety of ways with. You could probably dedicate an entire episode to teasing out mobility deficits, teasing out strength deficits. But I think some big take-home topics with this is when we have a patient with impingement, make sure we're ruling out red flags for potential structural defects. Rule out rotator cuff pathology, labral pathology, something intra-articular in nature. And then from there, think about our big buckets that we have from mobility, from a strength, from a movement quality standpoint. And then also just subjectively, when and how does this impingement come on? Does it tend to be very position and activity specific, or is it something that's more volume or duration? And I think that will help guide really our clinical decision-making of how and when we choose to intervene. So, Bami, I appreciate you doing the dirty work again to try to get through these articles and present them not only for our residency and our clinical staff, but for anybody who may be listening and is interested in really the evaluation and the treatment of shoulder impingement. So thank you, Bami.
Thanks, Zach.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.